First plenary session on muscle. If people could go ahead and take their seats now. Thank you. So I'm John England, and the co-chair of this plenary session is Dr. and Professor Wolfgang Griswold, who you all know because he's the president of this particular Congress. It's a great pleasure for us to open up the first plenary session here at the ICNMD 2018. And I think we have some wonderful speakers in store for you for this plenary session. Just a few issues before we get started. Please silence your cell phones, and please refrain from side discussions because it's disrupting to the speakers. We'll try and keep on time. Sometimes I'm not such a taskmaster, but Dr. Griswold is a taskmaster, so he'll make people stop. So each talk is 40 minutes. There's 35 minutes for the talk and 5 minutes or so for questions. So we'll go ahead and make a start. So our first distinguished speaker is Professor Volker Straub. Dr. Volker was trained as a pediatric neurologist at the University of Dusseldorf and the University of Essen in Germany. After his PhD thesis on Duchenne muscular dystrophy, he worked as a postdoctoral research fellow in the laboratory of Kevin Campbell at the University of Iowa. In 2003, he joined Newcastle University as the Harold Macmillan Professor of Medicine. He is currently the Deputy Director of the Institute of Genetic Medicine and the Director of the Newcastle University John Walton Muscular Dystrophy Research Center. He has a great research interest and knowledge of the pathogenesis of genetic muscle diseases and has done research using zebrafish and mouse models as well as other models. So it's a great pleasure to welcome him for the first talk, which is on pathomechanisms of muscle.
Thank you very much for the kind introduction, dear chairs, dear friends and colleagues. Before I start with my actual talk, I will first have a disclosure statement. First of all, I want to disclose where Newcastle is. It's in the northeast of England, and I have various collaborations with industry, none of which I think poses a conflict of interest for this talk. So when you're invited by the ICNMD to give a plenary lecture, you feel very honored, and I want to really thank Wolfgang and the organizing committee for the kind invitation to Vienna. But when I saw the title that was assigned to my talk, I did feel that this is quite a heavy topic, pathomechanism. Pathomechanisms in Duchenne muscular dystrophy would be difficult to cover, let alone pathomechanisms in muscle disease. So what you'll hear this morning is really a personal reflection from a clinical academic on pathomechanisms. I've used quite a number of figures. I apologize if I have not always assigned the correct reference from the internet. There are two messages in my talk. The first message is to really understand pathomechanisms, we need to work in an interdisciplinary fashion. And the second message you will hear at the end of my talk, just to keep your attention. Now, when we think about the concept of pathomechanisms in muscle, I think that this has very much been influenced by the way we see muscle. Now, the traditional view of a muscle is an anatomic structure with an origin and an insertion. And this is how medical students are still taught nowadays. And then there are other disciplines like physiology and biochemistry and genetics and more bioinformatics that have now contributed to the view we see muscle. I think the view of a motor unit is still extremely helpful with its four anatomical structures, the anterior horn cell, the nerve, the neuromuscular junction, and the muscle cell itself, and it forms the basis of our field, neuromuscular diseases. But more and more, we now see that muscle is actually depicted by technology, and that we have diagrams like these, where it's about big data, and it is actually machines that tell us how we are supposed to see muscle. I think all of these depictions are valid, but they all simplify muscle and the idea of muscle pathomechanism. Now, understandably, when we discuss muscle pathomechanisms, we look at the most important function of muscle, at contraction and force generation. And you could say, well, actually, that is the main pathomechanistic concept that is relevant for patients, because patients with muscle diseases finally experience weakness and wasting, a lack of force generation or a decrease in force generation. So that's what matters to them. And we could say, really, actually, for all the muscle diseases, it's the lack or the reduction in force generation that is the underlying pathomechanistic principle. Now, the puzzle, I think, when trying to explain and understand pathomechanisms is the heterogeneity of the features and phenotypes that we see in genetic muscle diseases. I think this is where it's really difficult to understand why we have, floppy babies and 80-year-old ones that, need a respirator and sit in a wheelchair. Why we have diseases where you have, a scapuloperoneal phenotype or facioscapulohumeral phenotype, where in some diseases the proximal muscles are affected and others the distal muscles. There are now more than 900 diseases listed in the muscle gene table, with only about 500 genes, many of them responsible for genetic muscle diseases. So this genetic this phenotypic heterogeneity, I think that's what's still puzzling. And muscle biopsies have, of course, helped greatly in our field to understand pathology, to contribute to the diagnosis. I think the neuromuscular field has really advanced because of the access to tissue. And the muscle biopsies will actually also show you some idea and principles of pathomechanisms, whether there's lipid accumulation or a lysosomal abnormality with acid phosphatase staining, whether there are autophagic vacuoles. All of these are pathomechanistic principles, or the storage of proteins like, of molecules like amyloid or glycogen. So all of this is really helpful, but does it explain the phenotypic heterogeneity, the selective pattern of muscle involvement? Not really. Now, when genetics came in and we had a better understanding of proteins as well, again, that was clearly advancing the field, understanding pathomechanisms, looking where proteins are expressed, whether they are sarcomeric or cytoskeletal, whether they are enzymes or membrane proteins or expressed in the nuclear lamina. But again, do our expression patterns of proteins give us any information why we have a selective involvement of muscles? Not really. So then with the expression of proteins and understanding where proteins are, we also realize which are the subcellular structures that are involved in muscle pathomechanisms. And from the nuclear lamina to the membrane, the Golgi apparatus, and the endoplasmatic reticulum, where there's protein modification, the sarcomere, mitochondria, the triad, the myoteninous junction, lysosomes, or the neuromuscular junction. All of these are really relevant structures that contribute when they are affected to pathomechanisms. But do they really explain why we have this distribution of muscle pathology? And then in the past years, more and more the way we look at muscle is through pathways and through molecular structures like the dystrophin glycoprotein complex, through signaling and complex molecular architecture at the myoteninous junction or the neuromuscular junction, muscle resealing. So there is clearly a better understanding now what is happening in a muscle cell. But again, does this help us to really understand why we have this complex pattern of pathology in various muscles. So, in summary, all of these advances that we have made in the field are enormous and very exciting, but they also have their faults because somehow they claim that this is what happens in muscle. All of these structures are, of course, in muscle cells, and we would assume that these proteins are expressed, most of them at least, ubiquitously, that these pathways are happening in all the muscle cells, but nevertheless, we have selective involvement of muscles. So, freely adapted from Gertrude Stein, a rose is a rose, is a rose is a rose. I think a muscle is not a muscle, is not a muscle, is not a muscle. And for those of you who know that I'm particularly interested in muscle imaging as well, you were wondering when will I show the first MRI slide. Here it is. Now, I'm not going through this quiz, but the MRI geeks can already try to figure out what these 9 diseases are. So these are 9 transversal sections through the proximal thigh and the proximal calf from 9 different diseases. And we have tried to figure out to recognize patterns as well, but leave that aside. I think what's really interesting is to look at the heterogeneity of the muscles that are involved and the differences. So, there are some diseases where the semitendinosus muscle in the hamstring seems to be selectively involved, and then in others it's selectively preserved, whereas the adjacent muscles are affected. There are some diseases where, yes, you have the posterior compartment of the thigh affected, but the calf seems to be completely fine. Then there are diseases where, just a single muscle, like here the sartorius, seems to be affected, and actually the semimembranosus muscle, one of the hamstring muscles, is missing. So you'll learn a little about anatomy here as well. But let's, for example, compare 2 diseases. So here in this thigh, you have the rectus femoris, the sartorius, and the gracilis, and the short head of the biceps femoris, all very well preserved. And if you look at this disease, you see that these muscles are really almost missing. And the question is a bit, well, does this tell us something about pathomechanisms? Is the reason why these muscles are preserved related to the protein that is missing in these patients? And if you look at these 2 examples here as well, which I think is even more fascinating. So here you have preservation of the central part of the muscle, whereas the periphery is affected. And it's even difficult to understand how that's possible because, it's one anatomic structure and it's not really based on motor units. And in this condition, it's exactly the opposite. So the center that is affected and, replaced by fat, whereas the periphery still seems to have good tissue. And again, is there something that we can learn about protein function based on this? So just to reveal the diseases. And there is, of course, a question, is this something that is generalizable? I mean, do all patients with vascular myopathy show this pattern, or all patients with POGLUT1 mutation show this pattern, as in this patient with LGMD2Z? And I think that's something that we still need to learn. We should always be careful when we think about pathomechanisms to generalize, keeping in mind that we are all individually different. But for example, if you look at Duchenne muscular dystrophy, you would say actually most of these patients show a fairly similar pattern of involvement. And yes, even though there is an individual difference, these are 2 patients without dystrophin, this one seems to be more severely affected. You can see that there's more fat in the muscles than this patient's. But if we look at the muscles that are best preserved, so the sartorius, the gracilis, semitendinosus here, that's the same pattern that you can see here. And even though there are always exceptions from the rule, like here this rectus femoris is really severely affected, nevertheless the semitendinosus and the sartorius and the gracilis are also well preserved. So we have to keep in mind there will always be outliers. Of course, the question is, can we learn something from them? But these might be individual outliers. And is this applicable to Becker muscular dystrophy? Yes, you would say that the pattern that we see in Duchenne is actually something that you also see in Becker, so there is some consistency in terms of the pathomechanism and the timeline in which muscles are involved, but something that is really fascinating and maybe will help us actually to understand pathomechanisms is by looking at individual muscles, like here the sartorius. Now, the sartorius muscle seems to be the muscle least affected in the leg by the absence of dystrophin or the non-function of dystrophin. And I remember that this patient here was walking into my clinic. I didn't expect him to walk because I saw his MRI before he came in. And again, it tells you something about how relevant muscles are for certain functional tasks. I think in an adult that is slowly adjusting to the loss of muscle, walking is actually not necessarily the best readout of muscle function. Now, when we look at MRIs and when we see patients with Duchenne or Becker muscular dystrophy, there has always been the question, well, is it maybe actually activity that contributes to the pathomechanism? Is that a pathomechanistic component? Should we advise patients to do exercise, or should we not advise them to do exercise? And how do you address this? Which are actually the muscles that are responsible for walking, for example. And the first time this was actually looked at in vivo was by Fujimoto et al., colleagues from Tokyo, who did a PET study in a patient that was running. There are now more sophisticated methods, and I want to just highlight this one study here from colleagues in Nijmegen, where they looked at 3D MRI with the reconstruction of muscles through semi-automated segmentation. And the study protocol is here. They had volunteers that went onto a treadmill, and they were walking on the treadmill for about 60 minutes. Then they were injected with the tracer, F18 labeled glucose, and then they continued walking, and then they stopped, and they were brought to the PET scanner, and then the activity was actually imposed onto the MRI. And what you see here, this is the combination of the 3D MRI and the PET results, that most of the activity was in the lower leg and in the gluteal muscles. Actually, the thighs are not really that relevant for walking, it seems, based on this assay where you look at in vivo metabolism through glucose and extrapolate that this is relevant for muscle activity and exercise. Now, which were the muscles that took up most of the radioisotope labeled glucose? So in the hip, the gluteal muscles, you can see this, and then in the thigh, it was in particular the vastus lateralis and the vastus intermedius and the vastus medialis together with the adductor magnus. These are actually the muscles that we see are most severely affected in Duchenne muscular dystrophy or Becker muscular dystrophy as well. And then have a look here. In the lower leg, it was particularly the soleus and the gastrocnemius medialis. So if you now see from these studies, okay, these are the muscles that seem to be most active when being on a treadmill in this case. Are these the muscles that are most severely affected? As I said, for Duchenne and Becker, this applies. But let's look at a few patients with limb-girdle muscular dystrophy. So here's a patient with a calpainopathy. And yes, the gluteal muscles are severely affected. But already, if we look at the thigh, it's the vastus that is well preserved, and it's the posterior compartment that is really affected. Yes, the soleus is really affected here in the calves, but if we look at the sarcoglycanopathy patient, it's a completely different pattern. So I think what we learn, and here with the anoctamin 5, I'm always puzzled to see how well the pelvic girdle muscles, the gluteal muscles are affected, even though they are the ones that are supposed to be really active when doing exercise and walking. So exercise and activity is not the principal component that explains pathomechanisms, not how we use the muscles necessarily. Clearly, it contributes to it. Because even if we look at diseases that join the same molecular structure, like in the DGC, there are clear differences. We don't really understand why the sarcoglycanopathies seem to have fairly well preserved calf muscles. It's really a pure limb girdle proximal muscular dystrophy, not at end stages, but for a long time. So maybe we again need to go back to the anatomy and the architecture and the mechanics of muscle. And of course we know from medical training that muscle architecture is very different. You have parallel muscles, you have different pination, unipinnated, bipinnated, multipinnated muscles. The pination angle is actually very important in terms of force generation. So again, it might therefore be important to not just look at activity, but actually force generation specifically for fibers in certain muscles. We of course also know that, for example, the uptake and the use of glucose will depend on the metabolic profile of muscle. And that's one of the limitations of the glucose uptake study with the PET and the MRI, that you say, well, what is the metabolic state? Maybe there is sufficient glycogen stored in some of these muscles, and therefore they don't need to take up glucose. So looking at the metabolism, of course, will also inform us about pathomechanisms. And we do know that metabolism, of course, is very closely related to performance. If you just look at Olympic athletes, you can tell whether there's a marathon runner or a sprinter or a weightlifter. And we, of course, know that beside training is very important, there are also genetic dispositions in terms of your performance. And just looking at probably the best described ones, I've listed those three. There are variants in alpha-actinin 3 that influence endurance and sprinting, and this was first described by Kathy North's group. And of course, we all know about myostatin. It's more than 20 years ago that McPherson published the myostatin knockout mouse, and Markus Rühlke, then the one patient with a homozygous myostatin mutation. Then we know that there are different alleles for the angiotensin converting enzyme. There's an I and a D allele, which makes the muscle fiber more vulnerable to exercise-induced damage, and the CK level is a good marker for this. And we know that this is very relevant actually for particularly endurance athletes. So they're all different genes then and proteins that affect muscle performance, which is relevant for understanding pathomechanisms. There's an interesting review from Fairberger et al. From Munich, where they looked at 47 genes that influence muscle hypertrophy and therefore also muscle atrophy and muscle mass. And they looked at these genes in terms of either a gain or loss of function in mice. And it was very interesting to see, and this is the total muscle weight of individual muscles in the cross-sectional area, how these 47 genes influence muscle mass in individual muscles. And it's quite interesting that most of these genes are involved in transcription and ubiquitination. And the three main signaling pathways in which these 47 genes participate are these three signaling pathways: the myostatin SMAT signaling, IGF, AKT, mTOR pathway, and the angiotensin bradykinin signaling pathway. And we know that these pathways are, of course, relevant for protein degradation and protein production, and that depending on their regulation, this can either lead to muscle atrophy or muscle fibrosis. And what we also know is that these pathways are not just influenced by the polymorphisms that I mentioned in the previous slides, but by exercise. So if you do not exercise, you actually tend to rather go into a state of inducing muscle atrophy and fibrosis, which is of course very relevant for patients with muscle diseases because many of them cannot really exercise that well. And we also know that in order to do exercise, there are some people that are better than others, and there's a review here from Del Cosso et al. From Madrid, where they looked at a few of these polymorphism and variant that have been described by others, and whether there is a polygenic profile to resist exertional rhabdomyolysis during a marathon. And so we know that some marathon runners, after they finish, have an elevated serum CK activity, whereas others don't seem to have any problem with this. And so they looked at a cumulative score, whether it is favorable to have a certain polymorphism in those 7 genes, and then looked at the ones who did not have a high CK and those who had a high CK after finishing the marathon. And what they did very well, they really controlled the 2 groups, both of them about 30 marathon runners. They had the same training regime, the same finishing time, the same demographic factors. And so there's a favorable polygenic score, really, whether you damage your fibers or not. So what this tells us is that there is clearly the need to do exercise if you want to be a Usain Bolt. There is a genetic background that really influences your performance. And I think what is very important, I mean, people have looked at this and it's becoming a real science. Eat properly. And this is a pathway that is the same that I have just shown you, but here from a journal that actually looks more at diabetes and nephropathies. But is this relevant for muscle? I think it is, because these are nutrient-sensitive pathways as well. And you will see that autophagy and inflammation and fibrosis are all downstream effects that are relevant for patients with muscle diseases as well. And so there was a recent BBC report, and David Rubenstein from Oxford actually featured in this about autophagy. And it says, can the science of autophagy boost your health? And I like the sentence here: a little known scientific process is being hailed as the new way to lose weight, look younger, and prolong life. So, all based on what you eat. Now, of course, that sounds oversimplified, but nevertheless, to see how at least diets or fasting can influence this, and also knowing how patients, particularly with some muscle diseases, and those who are on steroids in Duchenne muscular dystrophy have real problems with weight, I think all of this contributes to the pathogenesis. And exercise is really, I think, now hailed as the real polypill. And that's a problem for patients with muscle diseases, particularly those who are wheelchair bound. And maybe this is something, again, that we need to pay a lot more attention to. But then the other question is, well, is this really the case? I mean, should patients do more exercise, or could that not be damaging? And in our large natural history study on patients with dysphilonopathy that's funded by the Jane Foundation and is supported by the Synergy Network as well, where we have enrolled more than 200 patients now. We followed them for 3 years and collected a lot of demographic data. There's a poster, actually, that I'd like to point your attention to. We have looked at patients that were extremely active during teenage years, because for dysphilonopathy, this had been reported. Many clinicians noticed that the history of these patients is often one of high activity and very sportive. And so we had a scale here. We ranked patients in 4 different categories, from no physical activity to vigorous activity multiple times per week. And this was quantified as well in terms of metabolic equivalence. And we then looked at our cohort of patients, and we realized that those who did vigorous exercise in group 2 and 3 presented symptoms of the disease significantly earlier than those who did not do any exercise. And they were significantly more frequently wheelchair users. So maybe there's a disease where you would say, well, exercise is not necessarily favorable. I mean, we need to look into this in more detail. We will now actually look at MRI images and coming back to muscles that are involved. This is a heat map here just from the thigh of 179 patients with dyspholinopathy. And we can specifically look at the muscles that are most severely affected and those that are less severely affected, and can now go back to the individuals that did exercise vigorously. Can we see certain patterns? Does this tell us about which are the muscles that are more involved? If it's exercise related, we could get back to the study I showed you about the PET MRI and look at the muscles. So here in this heat map, we have listed the years of disease duration, so more than 25 years, 20 to 25, down to less than 5, and the severity of muscles involved. And the soleus is the muscle that is most severely involved, which was also the muscle that is most active when you at least look at the glucose assay. But there are always exceptions, like the gluteus medius wasn't really that much affected. But again, I think that there is probably a contribution of exercise to the pathology in dysferlin deficiency, at least. So I've given you some information about the oligogenic aspects when it comes to the protection of muscle and, for example, CK elevation after marathon running. And we generally think, monogenetic diseases is what we deal with. It's so simple compared to complex diseases where you need to have, large cohorts of people or patients to come to, some variants that might influence disease progression and contribute to pathomechanism. And then often we use animal models, and I think also that's something where we need to be probably careful. Coming back to my initial puzzle, why do we see the phenotypic heterogeneity? Do we really see a facioscapulohumeral distribution or scapuloperoneal distribution in animal models? And how much can they contribute to that puzzle? But then also, is it really that easy to understand the function of proteins? And looking back at dystrophin, and it was mentioned this is where I did my PhD in, there's an ongoing discussion, what does dystrophin really do, even 30 years after its first description. I now like to see it as a spring screw. And so the other protein, of course, that is very similar to dystrophin is eutrophin. And well, you would think, well, it's probably also some kind of spring screw. But do we really understand why eutrophin is replaced by dystrophin? Which protein was first? What are the differences in function? Why is eutrophin still expressed at the neuromuscular junction? So actually, even in the monogenetic diseases, which is our bread and butter on an everyday level, it's very difficult to necessarily understand protein function. And then, of course, if you look at a toolbox of screws, which is what we face in the muscle fiber, it becomes even more complex. If we now know that rare but maybe common variants influence pathomechanism in muscle diseases, then we have the problem that in our rare diseases, we will never have enough patients to really test this. So I think it's really important to look also at population studies and see which are the modifiers that we may then test in our disease cohorts. This is another slide that just shows you the polygenic or oligogenic trait that might contribute to pathomechanism. This is from our MyoSeq project. Many of you will be collaborators in this project where we have sequenced now almost 1,500 patients with limb girdle weakness across Europe. This is a summary of about 1,000 patients. And in more than 2 to 3% of the patients, we found mutations in 2 genes that have previously been defined as clearly pathogenic. So what in the literature has been described as double trouble is actually, I think, more frequent than we think, and with exome and genome sequencing, we will find this more and more. So understanding pathomechanisms in muscle, I have really so far mainly focused on muscle. But when you then look through the literature, you realize actually there are more and more other tissues that most likely contribute to the pathology in muscle. And we now know this for, of course, the smooth muscle and the hard muscle. But the vasculature itself in many diseases, including dysphalanopathies, for example, it's also the immune cells, bone, in Duchenne, also the brain in other diseases. So understanding pathomechanisms also means having a very good understanding of the expression pattern of your genes and proteins of interest, and maybe we need to look a lot more beyond muscle. And I think another aspect, and I said this is a talk about reflections, about understanding pathomechanism, is looking at the evolution and ontogeny of muscle. And muscle has not just been used for force generation, but also for heat production. And maybe when we learn more about similarities between different species, is where we get a better understanding why certain muscles are more effective than others. And I just want to briefly reflect on this concept that Miranda Grounds and colleagues had proposed, that growth might influence actually and exacerbate the necrosis of dystrophic myofibers, and that there's of course a clear difference between the mouse, which is fairly mildly affected, the dog, and then to human boys. Now this is the last summary slide of muscle pathomechanism, summarizing what I've tried to reflect on, that clearly there are genetic influences that determine muscle pathogenesis. We are most familiar with pathogenic mutations in certain genes, but variants will really contribute to the phenotype. Then there are environmental influences. We start to look more at activity and exercise. Nutrition is probably something important, and then of course medication as well. And I think what this diagram is supposed to show is that, of course, growth and aging are main contributors to pathomechanisms. And while we accumulate cellular damage with aging and lose our ability for an adaptive response, this will influence how the diseases progress in children or in adults. It's very interesting, I think, to see that there are some diseases that show a strong progression during childhood and almost become stable after puberty, whereas other diseases, again, like the dysphalanopathy, seem to be, fairly unsymptomatic during growth, but become symptomatic after puberty. It's also important that we keep in mind that some of these denominators, like inflammation or contraction-induced damage, are not necessarily good or bad. It depends, at what age, at what stage, and how long you see them. And inflammation and contraction-induced damage are physiological processes that can also be very good. So I told you already one of the messages of my talk at the beginning is that we have to work more interdisciplinary. That's clearly something that I learned in preparation of this talk as well. We may need to work more with, sport physiologists, exercise experts, people that understand metabolic diseases better, maybe even looking at nutrition. Clearly, all the new developments in terms of bioinformatics and big data come in as well. So interdisciplinary work is very important. And then the second message is, well, if we have more effective treatments, we might not need to really worry about pathomechanism. Once something is fixed, it's okay, and who cares really what happens in detail once we have an effective treatment. So that's what we should aim for. Now I'd like to thank the team in Newcastle for all its support. We are currently extending our team with senior positions, both in basic science and in clinical science. If there are any interest, please come and find me or contact me by email. And finally, I would like to thank you for your attention. Thank you very much.
Volker, thank you for that very comprehensive and organized talk. I think we have time maybe for one or two questions. If there's a microphone here, if you have a question, if you could come and introduce yourself If anybody has a question, we have maybe 3 minutes left.
So I'm Pavel Simon from Prague. It was very nice overview or exciting. But about the pathomechanism in the classical phenotypes, is it something known why, for example, dystrophin is important for these particular muscles which are affected, or in, I don't know, why is lamin AC important in these particular muscles, or in oculopharyngeal muscle dystrophy, because this is very long time known. You can confirm it in MRI or in these PET scans, but is it explainable also on the molecular level somehow, or? I know this is for another lecture.
Well, if there would have been an obvious explanation, I would have shared it. I think what people are starting to look at now, and I actually support this approach, that we need to look at probably the omics approach in individual muscles, and ideally, of course, in controls in patients. You can, I think, only do this effectively across many centers, because it will be difficult to collect this tissue. Unless you do a post-mortem analysis of muscle, which might change many of your expression profiles. It's very difficult to do this in a systematic way. I mean, I would have an idea of how you could tackle this, but again, practically, I think it's very difficult.
Anna Maria De Luca, University of Bari. Thank you, Volker. This has been very, very nice. I have just a question for you. I mean, don't you think that we have also to think what genetic defect does to ability of skeletal muscle to adapt to exercise? So we always look at what exercise does to pathology progression, but maybe we should think also that the genetic fingerprint may actually alters the ability of the muscle in relation to muscle fiber phenotype or pennation, as you said, to adapt, to properly adapt to the exercise.
I can only agree with this. I think that there's a very close crosstalk, that exercise, of course, influences the expression of genes. The expression of genes, of course, influences the way you can exercise, because it will change your metabolic profile of muscle fibers. So yes, the interaction is the complexity why it's so difficult to find, one single point, a gene that explains pathomechanism.
So please join me in thanking Professor Straub again. Thank you very much.
Well, thank you. For all of those of you standing in the back, there are some seats left here in front. You don't have to stand, sit down, use the seats. I have the great pleasure now to go to the next topic and introduce the next speaker, which is Professor Andrew Mammon from the United States. He will be speaking to us about mechanisms in inflammatory myopathies. Dr. Andrew Mammon completed his MD and PhD at the Johns Hopkins University School of Medicine, and then finished his neurology residency and neuromuscular fellowship in the same institution. He co-founded the Johns Hopkins Myositis Center in 2007, and he and his colleagues at Hopkins discovered a novel form of autoimmune myopathy associated with statin use and autoantibodies known as HMG-CoA reductase, which is the pharmacologic target of statins. In 2014, Dr. Mammon moved to the NIH, where he's an investigator and leader in the field of muscle disease. He maintains an appointment as an adjunct professor of neurology and medicine at Hopkins. So thank you for coming, and we look forward to your lecture.
All right, thank you, Professor Griswold. Thanks to the committee for inviting me also. It's been great to spend the last few days in Vienna. Dr. Griswold gave us, I think, the top 5 things we need to see in Vienna. I've only hit the top 3, so I think I have some work to do after my talks are done today. I'm going to be talking about inflammatory myopathies, in particular myositis. It's sort of a big topic, and I'm going to try to give an overview. I think I usually think of there being 4 major types of autoimmune disease. The 4 major categories we now think of are dermatomyositis. The anti-synthetase syndrome is probably something separate from that. There are the immune-mediated necrotizing myopathies, and then we also think of inclusion body myositis as being a separate disease also. So some of you might be asking, well, what happened to polymyositis in this grouping? And I think most of us now recognize that what we used to think of as being polymyositis is usually now categorized as one of these 4 other types of diseases. Either inclusion body myositis, it's misdiagnosed as polymyositis because of the lack of rimmed vacuoles in about 20% of the cases. Most cases of immune-mediated necrotizing myopathy would have previously been categorized as polymyositis. We now think of that really as a separate disease. The anti-synthetase syndrome is a multi-system disorder that affects a number of tissues, including lung and joints and muscle and skin. And in patients without skin manifestations, we would have called that polymyositis as well. And then, just as we know that there are dermatomyositis patients who are amyopathic and don't have muscle involvement, there are probably also some dermatomyositis patients who actually don't have skin involvement, who either haven't yet, developed skin involvement, but we think have dermatomyositis based on the presence of a characteristic perifascicular atrophy or one of the dermatomyositis-specific autoantibodies. So polymyositis is becoming less and less common because of these other known diagnoses. So I like to think of these different diseases as the 4 major types, but also we have the ability to subtype them even further, I think, based on the presence of myositis-specific autoantibodies. So with the anti-synthetase syndrome, we have anti-Jo1 or anti-histidyl-tRNA synthetase autoantibodies, as well as 6 or 7 other anti-synthetase autoantibodies that really define a unique phenotype. And each of these actually has a different, a slightly different phenotype. So for example, the anti-Jo1 patients, about 90% of them have myositis and only about half of them have interstitial lung disease, whereas patients with anti-PL12, which is one of the other anti-synthetase autoantibodies, about 90% of them have interstitial lung disease, but only half have myositis. So you can sort of define these subtypes, which form even more homogeneous groups. Similarly, there are now 4 major dermatomyositis autoantibodies: anti-MI2, anti-TIF1 gamma, anti-NXP2, and anti-MDA5. And these each have different characteristic features as well. I'm not going to go into them in detail here, but I just would let you know that anti-MI2 patients seem to have particularly severe muscle involvement. Anti-MDA5 patients, unlike the other dermatomyositis patients, also sometimes develop a rapidly progressive form of interstitial lung disease. They also have characteristic skin ulcerations that are not seen in other forms of dermatomyositis. The anti-TIF1 gamma positive dermatomyositis patients are the dermatomyositis patients who are most at risk for cancer and require aggressive cancer screening. And then anti-NXP2 patients are more prone to developing calcinosis. So again, just to emphasize that the antibodies define more homogeneous subgroups. Immune-mediated necrotizing myopathy has 2 associated autoantibodies, the anti-signal recognition particle or anti-SRP autoantibodies that have been known about for a long time, and then the anti-HMG-CoA reductase autoantibodies, which have been more recently discovered. And again, only the anti-HMG-CR patients seem to be triggered by statin use, so there's some difference there. There's also a new autoantibody that's been recognized to exist in a large percentage of patients with inclusion body myositis. It's not a myositis-specific autoantibody per se because we see it in some other autoimmune diseases, but nonetheless there are some differences between those patients who have and don't have anti-NT5-SUNA autoantibodies. So I think that studies that look at homogeneous groups of patients are probably the most useful. So I think studies that divide the patients into dermatomyositis, immune-mediated necrotizing myopathy, the anti-synthetase syndrome, and IBM are most useful. But even better, and we're starting to see studies of this nature recently, is when the studies further subdivide patients by the presence of different myositis autoantibodies. And I'm hoping that we're going to learn more about these diseases as we are looking at more homogeneous subgroups. So I'm going to start by telling you what we know about dermatomyositis pathomechanisms. I'll tell you at the outset, we don't know what causes dermatomyositis, so you're going to hear my own sort of personal view for how to put together some different clues that we have. I think most of you know that the hallmark muscle pathology for dermatomyositis is the presence of perifascicular atrophy, which we see in about half of the dermatomyositis patients. There's the classic heliotrope rash and the Gottron's papules, which are really pathognomonic cutaneous manifestations of dermatomyositis. And then nail bed abnormalities are also very classic and provide us some clues in patients who have dermatomyositis. So it turns out that there are genetic predisposing factors for developing dermatomyositis, and one of the more important ones is being female. And so not only are women more likely to develop dermatomyositis than men, but even among children who have juvenile dermatomyositis, more girls, even prepubescent girls, get the disease than do boys. So there's something with that. Also, patients with dermatomyositis have an increased frequency of having a first-degree relative that also has an autoimmune disease, not dermatomyositis, but something else, where about 16% of dermatomyositis patients have a first-degree relative compared to about 4% among healthy controls. Also, we know that class 2 HLA alleles confer some of the risk for developing dermatomyositis. In particular, among the Northern European population, the 8.1 ancestral haplotype seems to be particularly important in conferring susceptibility. And also, it's been shown that there are alleles in certain other molecules that are involved in the immune system that seem to predispose patients to developing dermatomyositis, including alleles in TNF-alpha and interleukin-1 beta. So that's the sort of genetic predisposition. We also know that there is at least one environmental exposure that predisposes patients to dermatomyositis, and that is ultraviolet light exposure. So it's now well established that this is the case, and there are a number of studies showing that ultraviolet light exposure predisposes people to dermatomyositis. This is one example of a study looking at juvenile dermatomyositis in the United States, and they've divided up the country into various regions with different degrees of UV light exposure, and then they're looking at the percentage of patients who have myositis, who have dermatomyositis, and it turns out the more UV light exposure you're exposed to, the larger the chance that you're going to develop dermatomyositis. And there's other evidence suggesting that this is the case. I think another thing that is strongly associated with dermatomyositis is the presence of malignancy. So this is still, I think, one of the nicer studies from 2001 by Hill and colleagues, where they looked at the pooled data from 3 countries where they had access to discharge medical records from both patients with other types of diseases and dermatomyositis. And they were able to look at 618 cases of dermatomyositis, among whom 32% had a malignancy. And it turned out that there was an increased risk for developing malignancy in the dermatomyositis patients compared to the control population. There's about a threefold increased rate of cancer in those patients. This is a table from that same publication showing that at time 0 is when you have the diagnosis of dermatomyositis, and in the years prior to 2 years prior to developing dermatomyositis, and in the year following the diagnosis of dermatomyositis, you have an especially increased risk of developing a malignancy. And as I alluded to in one of those opening slides, the thing that seems to be most tightly associated with malignancy in dermatomyositis is the presence of autoantibodies recognizing TIF1 gamma. So this is a nice study by the Spanish group, a meta-analysis looking at 6 studies with 312 adult dermatomyositis patients, among whom 66 had TIF1 gamma autoantibodies, and there were also 53 cases of cancer in this population. And the testing for TIF1 gamma had a positive predictive value of 58% for defining patients who had malignancy, and the negative predictive value was 95%. So this is an autoantibody that can be useful in defining that at-risk population. Again, the Spanish group, Iago Pinal-Fernandez, Professor Grau, Professor Selva O'Callaghan, recently published this paper where they did whole exome sequencing of tumors from patients who were TIF1 gamma positive and TIF1 gamma negative. And what they found were that there were mutations and loss of heterozygosity at a higher rate in the TIF1 gamma positive patients compared to the TIF1 gamma negative patients. And so they theorized that TIF1 mutations may play a role in triggering dermatomyositis, and that the tumors may actually be immunoedited by the immune system, resulting in this loss of heterozygosity at the TIF1 alleles, again, providing evidence that some mechanistic evidence for how malignancies might be associated with the development of autoimmunity. So there are a number of different ways to think about the pathology of dermatomyositis, and one way to think about it is as a vasculopathy. And you can see this by looking at the skin. I talked about in the beginning about how the nail beds are involved, and you can do capillaroscopy, which allows you to look at these very nicely arrayed sets of capillaries in the nail bed. And this is what normal capillary distribution looks like. And these are the capillaries from a patient who has dermatomyositis. And what you can see are that there are microhemorrhages, there are dilated capillaries, there are large-sized capillaries. And you can see this, the difference between normal and a dermatomyositis patient at high power. So evidence, just even looking at the skin, at the capillaries in the skin, you can see that there's damage to the capillaries. If you do a skin biopsy, you can see that there are perivascular lymphocytic infiltrates in the skin. Similarly, we know that perivascular inflammation is a prominent feature of the dermatomyositis muscle biopsies as well. I think Alan Pestronk did a very nice study a few years ago looking at capillaries in the muscle. And what they found, what Alan Pestronk and his group found was that away from areas of perifascicular atrophy, far away or a normal muscle, there are these nicely formed capillaries in the endomysial spaces around muscle fibers. As you get close to the areas of perifascicular atrophy, but not in the area of perifascicular atrophy itself, you start to see abnormally shaped capillaries. So here's some dilated capillaries near the perifascicular atrophy areas. And then within the areas of perifascicular atrophy, all you see are remnants of capillaries. So there's significant capillary dropout, suggesting that, again, the capillaries are involved, capillary loss is involved in the perifascicular atrophy or a result of it. This is just another image where he showed that there are remnants of capillaries located near these perifascicular areas, and away from the perifascicular areas you have relatively normal looking capillaries. The Pestronk group also looked at H&E sections, and they looked not just at capillaries, but at the medium-sized blood vessels in the paramecium. So right here, you can see relatively normal paramecium with medium-sized blood vessels. And then you can see avascular paramecium. And it turns out that the perifascicular atrophy is located near avascular paramecium, suggesting that it might be ischemia from dropout of these sort of feeder medium-sized blood vessels that's causing atrophy and damage to the more local myofibers. So that would be sort of the watershed area of the muscle. And there's some more recent evidence suggesting that dermatomyositis muscle might actually be undergoing some ischemia. This is a recent study by DeLuna et al. And one of the things they showed in their study is that HIF1 alpha protein, which is upregulated in response to ischemia, is upregulated in dermatomyositis muscle and sometimes in the perifascicular area, again, supporting this idea that hypoxia and ischemia may be playing a role in the damage. So You can think about DM in terms of it being sort of a vasculopathy. I think another way to think about it is as an interferonopathy. So this idea comes from work by Steve Greenberg and Tony Amato, where they looked at muscle biopsies from patients with dermatomyositis compared to controls. And what they found was that type 1 interferon-inducible genes are overexpressed in dermatomyositis muscle. So that was sort of, I think, the first clue that interferon may be playing an important role in this disease. And they identified some interferon-inducible proteins and stained for them, including here MXA. And what you can see is that MXA protein, which is an interferon-inducible protein, is upregulated and often in a perifascicular pattern in these dermatomyositis muscle biopsies. Where might the interferon come from? Well, knowing that there was this interferon signature, they were able to look for plasmacytoid dendritic cells in muscle. And plasmacytoid dendritic cells are potent secretors of interferon. And it turns out that there are lots of these that are present in the muscle biopsies of patients with dermatomyositis. So that's one potential source of the interferon that's causing the upregulated interferon gene expression. Turns out interferon is not just important in the muscle. There's also an interferon signature in the skin. This is work done by Dave Fiorentino and his group at Stanford, where they found very similar results in skin from dermatomyositis muscle patients. And this interferon signature is actually associated with disease activity. So this is looking at a number of interferon-inducible genes as sort of a composite score, the interferon score here, and showing that the higher the degree of the interferon score, the higher the degree of disease activity. So there's some correlation there. And there are numerous other studies showing that interferon gene expression in the blood is associated with the disease activity. So there are lots of other molecules and pathways that have been proposed to be important in dermatomyositis. So for example, numerous cytokines have been implicated. These include a number of different interleukins, TNF-alpha, TGF-beta, B-cell activating factor. You can find that there are T cells that include granzyme B and perforin that might be mediating muscle damage in dermatomyositis muscle. And then there are molecules that might be actually be important for attracting inflammatory cells into the muscle. These would include ICAM, VCAM, and the selectins. So again, we don't really know how dermatomyositis works exactly, how it's initiated, how it's maintained. This is my own sort of personal view. I consider it sort of a working model to stimulate discussion more than anything else. But we know that there are these genetic susceptibility factors, being female, having certain HLAs. We know that there are environmental triggers, such as UV light, maybe certain types of infections are also important. And then we also know malignancy plays a role in some patients who have dermatomyositis. And these all come together in ways that we don't quite understand to initiate autoimmunity. And when patients have the autoimmune response, they develop inflammation in their muscle cells, which can directly cause muscle damage. Inflammation might also damage the blood vessels, leading to muscle ischemia, which could cause muscle damage. The plasmacytoid dendritic cells might secrete interferon that cause upregulation of interferon-inducible genes. Some of these genes, like MHC1, may actually cause muscle dysfunction as well. So this is just sort of a working model of how all these different factors I've talked about may come together to cause dermatomyositis and lead to pathology. So I'm going to switch to talking about inclusion body myositis now. So I think, as most people in this room are aware, this is a very different disease than dermatomyositis. Unlike dermatomyositis and other forms of autoimmune muscle disease, this affects men more than women, tends to affect older men over the age of 50. It tends to sort of have an insidious onset over years or perhaps longer and progress, in most cases, very slowly. It also has this unique pattern of weakness, which I was thinking a lot about during your talk. For inclusion body myositis, you not just have certain groups of muscles that are preferentially involved, like finger flexors, wrist flexors, quadriceps, and ankle dorsiflexors, but you also have this asymmetry, which I think is not well explained. Dysphagia is common, and unfortunately, these patients are very poorly responsive to immunosuppressive therapies, and we'll talk a little bit about why that might be based on what we know about mechanism. So if you look at the muscle biopsies from patients with inclusion body myositis, you see evidence of two different processes. You see evidence of myodegeneration You see these eosinophilic inclusions of abnormal proteins. You see rimmed vacuoles. You also see abnormal aggregation of proteins like P62 and TDP43, which suggests this is a degenerative disease. On the other hand, you also see prominent inflammation. This is one of our more inflammatory myopathic conditions, I think, where you have CD8 positive T cells that surround and invade otherwise healthy-looking myofibers. And you also have upregulation of MHC, which I didn't really talk about too much, but is also sort of one of the hallmarks of inflammatory myopathies. I'm really just going to focus on the inflammatory part and kind of neglect the degenerative part, since this is a talk on inflammatory mechanisms. And it's really been known since the 80s, since the seminal work of Dr. Engel and his colleagues at the Mayo Clinic, that CD8 positive T cells invade the muscle and damage muscle fibers. And then shortly thereafter, it was recognized that there are two populations of T cells. There are non-invasive T cells in the muscle, which are clonally diverse, and then there are clonally restricted T cells, which seem to be doing the job of invading the muscle fibers. And it turns out those clonal T populations, the same populations, are present in a single patient over time, over the years. Those populations can be stable. The same clones are found in different muscles from the same patient, and the same clones are found both in the blood and in the muscle tissue. So this clonality of the invasive T cells suggests that there's some antigen-driven process which is driving that selection and that clonality in inclusion body myositis. So again, Steve Greenberg, Tony Amato, and others have done some really nice work recently, and I think this is a really important observation, that close to 60% of inclusion body myositis patients have abnormal T cells in their blood that really fulfill the criteria for T cell large granular lymphocytic leukemia. And so you can see that they have abnormal leukocytes with these, that have these eccentric nuclei. Some of them you can see cytotoxic granules. These are clonal, they're stable over time. And importantly, this population of T cells, as in T-LGL, express this marker CD57. And it's known that CD57 positive T cells result when there's been persistent antigenic stimulation of that clonal population. They have increased cytotoxic potential compared to your normal CD8 positive T cells, and they are very resistant to apoptosis. So these are tough autoaggressive T cells. And it turns out among the 60% of patients who have these types of cells, they have more aggressive manifestations of inclusion body myositis. And they showed that these clonal populations of LGL-like cells are present in inclusion body myositis patients, again in about 60%, but they're not seen in other inflammatory myopathies or healthy control. So it seems to be relatively specific for this disease as far as we know. So these CD57 cells I told you about that were discovered in the blood are also in the muscle, invading the muscle. So this is a stain for CD57 showing CD57 positive T cells invading the muscle fibers. So they seem to be playing a significant role in the muscle. And the higher the prevalence of these abnormal lymphocytes you have in the blood, the worse your muscle inflammation is. So this is a muscle biopsy from a patient who had over 34% of these LGLs in the blood, and there's tons of lymphocytic infiltration. And then if you look at a patient who has only 5% LGLs, and you look at in their blood and you look at their muscle tissue, there's very little lymphocytic infiltration, and there's sort of intermediate values here. So there seems to be a correlation between the number of these cells in the periphery and what you get in terms of muscle damage. So what does all this mean? Well, one possible explanation is that there's been sort of persistent over years of stimulation of the immune system by antigens in the muscle or elsewhere, I guess, that have precipitated the production of these sort of neoplastic autoaggressive T cells, that they don't really have LGL, but they have cells that are similar to the ones that are found in LGL. And the presence of these cells and the importance of these cells in invading the muscle might be one reason why inclusion body myositis patients are particularly resistant to treatment. As are LGL patients, they don't respond well to traditional immunosuppression. But I don't want to leave you with, I think, the idea that most IBM patients have TLGL, because there are differences between your typical TLGL patient and your typical IBM patient. So for one thing, LGL does not discriminate between men and women, whereas inclusion body myositis tends to affect men more than women. And other features that you see in TLGL patients, such as a severe neutropenia that can be associated with infection, not typically seen in inclusion body myositis. And the inclusion body myositis patients have a relatively good prognosis, whereas those patients who have more traditional TLGL actually have a 20% mortality after 4 years. But I think that discovering these cells is really important and may be an important therapeutic target. If you could specifically get rid of this particularly aggressive population of T cells, you might be able to help patients with inclusion body myositis, even if there is a coexisting degenerative component. And you could probably certainly also help patients who have LGL. So moving from the T cells to talking about B cells and autoantibodies, it was known since the 80s, again through seminal studies by Dr. Engel and colleagues, that there are very few CD20 positive cells in patients who have inclusion body myositis. But one of the things that came out of the gene expression profiling studies that Steve Greenberg did was that there are lots of immunoglobulin transcripts in the muscle. And that was really surprising since there weren't CD20 positive cells. So they stained for the cells that actually are secreting the antibodies, which are plasma cells. And the markers for these weren't available back in the 80s. But now we have markers such as anti-CD138 antibodies, which can recognize plasma cells. And it turns out there are abundant plasma cells in inclusion body myositis muscle. And along with the presence of immunoglobulin transcripts, it raises the possibility that maybe there are autoantibody producing cells in the muscle. And Steve Greenberg and others in Europe did work looking for such autoantibodies and recently found that there are autoantibodies recognizing a protein called cytosolic 5' nucleotidase 1A, which were found initially in patients with inclusion body myositis by both groups, sort of independently at the same time. What is NT5C1A? Well, it catalyzes the nucleotide hydrolysis to nucleosides, but its role in muscle function is actually poorly understood. As the name implies, it normally has a cytosolic distribution. But in patients who have inclusion body myositis, it is found in the perinuclear regions and also near rimmed vacuoles, suggesting that it's mislocalized in patients with inclusion body myositis. Perhaps this is one of the reasons why it's targeted by the immune system, although that remains to be shown. One of the really interesting things about the autoantibody was that it was found in a lot of patients, in this initial paper up to 70% of patients with inclusion body myositis, but in far fewer patients who have other inflammatory myopathies. Although when you look, and other neuromuscular conditions, although when you look at the dermatomyositis patients, even in this initial paper, you can see that several of the dermatomyositis patients here are actually NT5C1A positive by this assay. So our group and other groups, including the group in Europe that discovered the NT5C1A, have shown that this antibody is not just present in patients who have inclusion body myositis. It's actually found in about 25 to 35% of patients who have Sjogren's syndrome. It's found in 15 to 20% of patients with lupus, and about 15% of patients with dermatomyositis. I think it's important to point out that these patients with Sjogren's and lupus have the antibody, but they don't have muscle involvement as part of their disease. So this is an antibody that I would characterize as a myositis-associated autoantibody. It's found in inclusion body myositis, dermatomyositis, but also in some other rheumatic diseases. Still probably useful, perhaps particularly to rheumatologists, to identify patients who have inclusion body myositis when there's confusion, but not specific for myositis. Even though it's not specific for inclusion body myositis, it turns out that inclusion body myositis patients who have this autoantibody actually have more severe disease than inclusion body myositis patients who don't have this antibody. So this is recent work by Tassin Mozafar's group at UC Irvine, and they looked initially at 25 inclusion body myositis patients. 17 of their patients were positive for NT5C1A, more females than men. And these patients took longer to get up and stand, required more assistive devices, and were more likely to have dysphagia and or facial weakness compared to patients without the antibody. And the idea that the disease is more severe in patients with the antibody was confirmed by the European group, who looked at over 300 inclusion body myositis patients, a third of whom were anti-NT5C1A positive. These patients who are positive have higher adjusted mortality risk, and they also had an increased incidence of facial weakness. So again, suggesting that the antibodies are associated with maybe a more hyperactive immune system with maybe a more profound immune response that's causing worse disease. One thing you might have noticed is that it's like, more than 2/3 of patients in that group are NT5C1A positive, whereas only a third are NT5C1 positive among the European group. Unclear if that's because there are actually geographic differences in the prevalence of NT5C1A, but those groups also use different antibody detection methods, and that might be part of the issue as well. All right, could the anti-5C1A autoantibodies be pathogenic? I doubt it, but there's a group that has done some work on this. So a Japanese group took these antibodies and grew cultures of rhabdomyosarcoma cells in a tissue culture dish and treated the cells with the anti-NT5C1A autoantibody, and they found accumulations of P62 in the myofibers. And P62 is one of the proteins that accumulates in the myofibers of patients with inclusion body myositis. They also did some passive transfer experiments where they injected NT5C1A autoantibodies into mice, and the mice who got the autoantibodies injected had P62 accumulate in their myofibers. But I guess I'd point out that only about 0.04% of the myofibers had P62 inclusion, so that seems pretty small. Also, the mice didn't develop other characteristic features of inclusion body myositis, no rim vacuoles, no inflammation by T cells, and also no muscle weakness could be observed in these animals. And I also have some doubts about the pathogenic role of NT5C1A because, again, we have these lupus and Sjogren's patients who have NT5C1A autoantibodies, sometimes at high titer, who don't have muscle involvement. So still something to think about. So the sort of models of how IBM develops, I think, are sort of notoriously controversial. I'm sure mine will be not universally accepted. Again, it's really meant as something to stimulate discussion and thought as opposed to a final answer. But I would suggest that maybe there are some individuals have a genetic susceptibility to some myodegenerative process. And over time, and as they age, they have some abnormal protein accumulation in their muscle, which causes some degree of damage to their muscle. And it might, in some people, really not ever be clinically noticeable. But in patients who have the right genetic susceptibility, they're male, they have the right HLA allele, and maybe they're exposed to some environmental trigger, you can have the initiation of some autoimmune process. Maybe that causes autoreactive T cells to go back and damage the muscle. And when you have muscle damage, that leads to cellular stress, which can cause more abnormal protein accumulation, which causes more damage to muscle. And then you get this sort of vicious cycle going that ultimately results in inclusion body myositis. Again, just an idea for how to fit all these different aspects of inclusion body myositis into a single model. All right, switching gears to talk about pathomechanisms in the immune-mediated necrotizing myopathies. So there are two autoantibodies associated with immune-mediated necrotizing myopathy, the anti-SRP and the anti-HMGCR antibodies. I'm going to talk about these two types of disease together because they have some similarities. They're both associated with necrotizing muscle biopsies. These patients have proximal muscle weakness, very high CK levels. In each case, the CK levels can reach 10,000 or higher. Both anti-SRP and anti-HMGCR patients have minimal extramuscular involvement. So they rarely have a rash, rarely have joint involvement. Sometimes your SRP patients will have mild ILD, but maybe only 1 in 5 or 6. But these are predominantly diseases of the muscle, in contrast to dermatomyositis or the antisynthetase syndrome. The other thing is that in each case, the autoantibody titers correlate with disease activity. The more antibodies you have, the weaker you are, and the higher your CK level is. But there are also differences between the anti-SRP and the anti-HMGCR patients. So they have different genetic predispositions. So there's a relatively weak association of this class 2 HLA allele, DRB1, 0803 for patients developing anti-SRP. In contrast, patients with anti-HMGCR myopathy have probably one of the strongest immunogenetic risk factors that's been described in an autoimmune disease. So they have a very strong risk factor with DRB11101 being present in about 75% of HMGCR positive patients compared to 10 or 15% of healthy controls, both in Caucasians, African Americans, and in the Asian population. So that seems to be a fairly strong genetic risk factor. Triggers for these diseases seem to be different. We and others have shown that in some patients, statins are a strong trigger for developing anti-HMGCR myopathy. That's not the case for anti-SRP. In contrast, anti-SRP patients all tend to present at a certain time of the year, a certain season, suggesting maybe an infection or some other environmental trigger is important. So why might statins trigger anti-HMGCR myopathy? We don't know for sure, but if you look at the cholesterol biosynthetic pathway, you can get some clues. As we remember back from medical school, cholesterol biosynthesis takes precursors and converts them to cholesterol, and HMG-CoA reductase is the rate-limiting step. Statins function by inhibiting HMG-CoA reductase, but there's a feedback loop. And when you inhibit HMGCR, you decrease cholesterol, but the low cholesterol levels drive production of HMGCR. So you get a big upregulation of HMGCR protein when you treat patients with statins. And it's thought that the increased amount of protein or maybe binding of the statin to the protein creates neoepitopes that help to break tolerance. We also know that regenerating muscle fibers express high levels of HMGCR. So it might be that even once you take the statin away, the increased levels of HMGCR in the regenerating muscle can serve as a continued source of the autoantigen. So are these autoantibodies pathogenic? Well, there's some evidence to suggest that they could be. I think one of the things that you'd like to see is that the antibodies can actually recognize SRP or HMGCR on muscle fibers. And it turns out that you can, Yves Allenbach and Olivier Bonveniste's group have shown that SRP and HMGCR protein are localized to the surface of myofibers in the disease state. They also have shown that IgG and C1q are localized to the myofiber surface, and that there's membrane attack complex on the muscle fibers here, suggesting that this might be a complement-mediated process, and perhaps the autoantibodies are able to activate complement-mediated cell death in these patients. So they've done some experiments in Paris, taking anti-HMGCR and anti-SRP autoantibodies and treating myotubes and myoblasts with the autoantibodies. And they've shown that both autoantibodies can inhibit or can cause muscle fiber atrophy in vitro. And similarly, these autoantibodies can inhibit myotube formation in vitro. They've done some further analysis and found that when you treat cells with these autoantibodies, you get decreased levels of interleukin-4 and interleukin-13 secreted by the myofibers themselves, and that if you go and add back interleukin-4 or interleukin-13 to these cultures, you can restore the normal myotube diameter. So that's one possibility. So there's no direct evidence that anti-SRP and HMGCR antibodies cause necrosis. It'd be nice to have some passive transfer experiments to confirm that's the case. Am I running out of time? Okay, so I only had a couple more slides. I'm going to leave those off because they're all about the anti-synthetase syndrome, which we actually know incredibly little about the pathogenesis of. I'm just going to show you the one slide from that, which is, I think, important, which is that patients with anti-Jo1 autoantibodies actually do have a very characteristic pathologic finding, which are these aggregates of actin in the nuclei, which you see only in the anti-synthetase syndrome and not in patients with other forms of autoimmune muscle disease. So I will stop there since I've taken all my time, and be happy to take a question if there's any time for that.
Thank you for your fascinating talk.
Sure.
It's hard for me to stop you too because it's so interesting. So, just one question, one urgent question.
Yes.
Yes,
So I'll
Dr.
go
Steinberg.
from Israel. I have, in fact, two questions that may be related. So, statins, is it only immune-mediated muscle disease or is it toxic? That's one question. And the other question, which you haven't touched upon, maybe that's a topic for that. We are talking about autoimmune myopathies without inflammation. What is inflammation doing in the hereditary myopathies, especially dysferlin and FSHD?
So to answer your first question, statins can commonly cause a low-level sort of statin intolerance, or more rarely a severe rhabdomyolysis. But the thing is that when you take the statins away in those cases, the muscle damage stops and the process tends to resolve. So in the patients with anti-HMGs, you don't find the autoantibodies in those patients, whereas in the anti-HMGCR positive patients, even when you take the statin away, you have a autoimmune process which, once it gets started, doesn't go away and you need to treat with immunosuppressive agents. And then I think your second question is a great question about the role of inflammation in genetic muscle diseases, but way beyond the scope of my ability to answer in a short time.
Thank you very much.
Sure.
We regret, but we have to continue. Thank you very much again.
Well, thank all of you. So the next and final speaker is Professor Hans Lockmuller. Professor Hans Lockmuller trained as a neurologist in Munich and in Montreal. He was appointed chair of experimental myology in the Neuromuscular Research Group at the Institute of Genetic Medicine of Newcastle University in 2007. He is currently chair of the Interdisciplinary Scientific Committee of the International Rare Diseases Research Consortium and former chair of the Executive Committee of the Treat EMD Alliance. He is co-founder and former coordinator of the German Muscular Dystrophy Network and former scientific coordinator of EuroBiobank, a European network of biobanks for rare disorders. His research interests are focused on the molecular genetics of inherited myopathies and neuromuscular junction disorders, and the study of animal models of these disorders as a means to understand their pathophysiology, as well as to develop means to monitor disease progression and therapy. His group's ongoing work in these areas in cell and animal models of muscular dystrophy are concentrating on gene transfer, pharmacologic interventions, and cell therapy. His talk for the last part of this plenary session is on genetics and, of course, the very hot topic of epigenetics. We're very pleased to welcome him. Thank you.
Well, thank you very much for the kind introduction, distinguished chairman, ladies and gentlemen. I want to display my disclosures, and I think one is particularly pertinent for this conference. I'm the editor-in-chief for the Journal of Neuromuscular Diseases, and the journal is proud actually for the third time now to team up with ICNMD to publish the abstracts of the conference. So thank you very much, Professor Krisold, for that privilege as well. I want to talk about genetics, and genetics I think is two things. One, it's a discipline, as you know, but secondly, it's a tool, and it's become a very powerful tool, and people would say a disruptive technology. And this is evidenced by the number of gene discoveries that has been made over the last couple of decades. And increasingly, this is through next generation sequencing, exome sequencing, and now genome sequencing. And these are basically the discovery rates of new genes for rare diseases or Mendelian disorders generally. But muscle disorders do actually make quite a large part of that. And there is certainly no month now, or sometimes no week, where we have not published at least a new gene, and it's becoming quite difficult at times to follow pace. And the other difficulty about genetics, of course, is that each of us has many different variants in the genome. And even just if you look at the coding sequence at the exome, there's about 25 to 50,000 variants in each of us. And to identify the one or two, or sometimes more, pathogenic variants is actually not a trivial pursuit. It's the needle in the haystack problem as depicted here. So while initially we thought with all this sequencing now, being able to look at an entire exome or an entire genome of a patient, we would have it easy as clinicians. We would take a DNA sample from a patient, certainly from a patient with a genetic muscle disorder, send it out for sequencing, and out comes the diagnosis and the report, and hopefully maybe some magical means of therapy. The way it is actually now is, well, you can send a sample for sequencing, but then a lot of people actually have a little bit of a headache making sense of all of this and analyzing the data. You need specialists, geneticists, bioinformaticians. Potentially you may need to look into animal models, into populations, and then potentially you come up with a solution, a diagnosis for your patient. But even that is currently not the case for all patients. So on average, between 30 and 50% of all patients that get exome sequencing, including patients with muscle diseases, do actually not have a clear diagnosis after next generation sequencing. So there's still a large number of patients with a lack of diagnosis, even if you have the means now at least to sequence the entire exome. What I want to do in my talk is, first of all, try not to go through all the different genes, and probably since the last conference, there's about 100 new genes being discovered, so I won't go through them one by one, but I try to make a little bit of sense and what to look for once you hear about these new discoveries or come across something interesting in your patients. Secondly, I want to take the scare a little bit out of this here. So I want to show you that, in fact, we shouldn't leave this, the interpretation of the genome, to the geneticists and to the bioinformaticians, because as I said in the beginning, it's not just a discipline, it's a technology, and it's a technology that becomes increasingly important also for neurologists and pediatricians and other disciplines that work with people, with patients with muscle disease. So let's look first at the more clinical aspects. What are the new learnings that we've come across over the last years in the genetics of the myopathies primarily? Well, and I give you examples after this first slide. So some mutations in well-known genes are difficult to detect. Some well-known genes show new phenotypes or new patterns of inheritance. New genes for well-known phenotypes are being discovered. Genes don't always respect clinical classifications. Mutation frequencies vary between populations, and some recognizable syndromes with extramuscular manifestations are caused by muscle gene defects. And then digenic inheritance, polygenic modifiers, epigenetics, well, that's just the beginning. So we have a lot to do still to understand the complexities of the genome and how it influences muscle disease. And then I will go into what we can do as clinicians and people who are interested in muscle research about sharing the data and solve the unsolved, which is still a pretty big problem. So starting with my first point from the list, some mutations in well-known genes are difficult to detect. So there's a nice publication by Daniel McArthur's group that showed that, in fact, including in some muscle genes, there's intronic mutations that do cause the same phenotypes as the exonic mutations, like in this case, a collagen 6 mutation that is deep intronic and leads to the inclusion of a pseudoexon, and that then basically disrupts the normal collagen 6 expression and leads to collagen 6 disease, Bethel myopathy, or Ulrich muscular dystrophy. Why is that important? Well, this mutation doesn't get detected by regular gene Sanger sequencing or by even exome sequencing, so you actually need to use another method, in this case, sequencing the RNA or doing genome sequence, or once you actually know this mutation, well, then you can do directed sequencing. The other why this is important is, well, if you understand this mutation, then in fact it's not far-fetched to think about a very specific therapy. So if you develop an antisense oligonucleotide that takes out the splicing that is being created here, then in fact you get back to normal wild-type protein for these patients. That's a therapy that's being developed by Carsten Bonnemann's group. So next point, some well-known genes show new phenotypes or new patterns of inheritance. So in this case, the tidin gene. So the tidin gene is, of course, one of the largest genes in the body, and it's been very difficult to make sense of all the variants in this gene, and most patients will have at least one, sometimes even several variants in tidin. Well, there, of course, have been several autosomal dominant diseases described with cardiomyopathy before and with HMERF, so hereditary myopathy with early respiratory failure. Increasingly, young kids have been identified that have B-allelic mutations, so recessive mutations in the tidin gene leading to congenital myopathies that have in the pathology either the central nuclear pathology or central core pathology. And these patients make now actually a fairly large proportion of congenital myopathy and have been described in this nice paper by Oz et al. Another gene that we actually thought about, we knew quite well, is the calpain-3 gene, so the most common of the limb-girdle muscular dystrophies. But previously, all of them have been thought to be recessive, LGMD2A. But very recently, John Wissing's group in collaboration has described families, large pedigrees, where in fact a single heterozygous calpain-3 mutation segregated with the disease, and they showed elegantly that this is in fact a dominant variant of calpain-3 disease. Next point to make, well, there's a number of new genes that are being discovered that cause well-known phenotypes. So this adds to the genotypic variability. The gene that I want to mention here is the kinase ZAC that causes a congenital myopathy with fiber type disproportion, which was a gene that made sense because it interacts with several other muscle genes and has been shown in mice to be causing a myopathy. Similarly, the gene INPP5K is causing a form of Marinescu-Sjögren syndrome. So this is a recessive condition, and there's a particularly frequent mutation in Pakistan that we came across quite a few times. These patients, in addition to their predominant limb girdle weakness, also show a mild degree of intellectual disability and also cataracts, even though the cataracts, they appear not to be present at birth, but start within the first couple of years of life. Next point is genes don't always respect clinical classification. So this is one example that we came across. The agrin gene is, of course, very important for neuromuscular transmission and was known to cause very rare forms of congenital myasthenia. However, we and Sophie Nicole, Bruno Emar's group in Paris, described several families that had a clear distal myopathy phenotype. So that was, of course, surprising to start with. It also did show a decrement. So they had a combination of a distal myopathy with a neuromuscular transmission failure. And basically, this might be explained through that agrin does, in fact, have a muscle isoform. So therefore, in addition to the neuromuscular transmission defect, these patients may develop a myopathy. Another similar example for genes that don't respect clinical classification is the GMPPB gene. So again, quite interesting was this discovery by David Beeson's group and others, a very basic sugar modification glycosylation gene that feeds both into the N-glycosylation and into the O-glycosylation. And those patients do show either muscular dystrophy, which makes sense in terms of the O-glycosylation, or congenital myasthenia in terms of the N-glycosylation. And some patients show actually both phenotypes. So this is from a sort of more traditional classification point of view, then causing you a bit of trouble. So is this now a neuromuscular transmission defect or muscular dystrophy? And it's causing you difficulties in terms of the diagnosis, because in earlier talks I've always said that if you have a patient where you have suggested myasthenia or congenital myasthenia, but you have a very high CK, well, then think twice, it might be muscular dystrophy, so not congenital myasthenia. Well, these patients have both. Another example, that's the last one for this point, genes that don't respect clinical classifications. So this is the SLC25A21 gene, which encodes the mitochondrial oxodecarboxylate carrier. And this gene is coming in a recessive trait and is linked to an SMA-like neuropathy, but also shows features of a mitochondrial myopathy. Importantly, it is critical to understand what is the particular mutation load in your specific population. So I give that example here for the distal myopathies. So mutation frequency vary between populations. So if while in one population, one particular gene may be the most prevalent for causing one disease, that's not true in another population. So here we have an example, again, for the tidine gene. Here, these are recessive variants that lead to a distal myopathy, a distal muscular dystrophy in patients from Serbia. Nicely described in this paper. While in another population, this is the Bedouin population of Kuwait, where Andoni Urtis Berea and others have been instrumental to identify these patients. 80% of patients with distal myopathy do have, in fact, recessive mutations in the GNE gene. So completely different from the population in Serbia, where it's mostly the tidine gene. Come now to a couple of conditions that you may not have had on your radar, but are still muscle diseases, and they are actually now linked to muscle genes. So this condition is called by the clinical geneticist Carey-Feynman-Sider syndrome, and actually I haven't heard about it until it was published, basically. But these patients have very typical facial features. But in addition, what they have, and what was probably underappreciated, is they have a clear myopathy phenotype, so they have muscle weakness. And we've seen a patient here, it's probably the oldest patient with this disease, that shares those facial features with the patients that have been described, but also have contractures in the hands and feet, and does have clear muscle weakness. So the solution is that all these patients have mutations in a gene that's called myomaker, and as the gene name suggests, so this gene is critically involved in fusions of myoblasts into myotubes, so it has a real a muscle gene function here. Another example where, in fact, other clinical features are critically important for the phenotype and help you to diagnose a patient is this disease that's characterized by dominant mutations in the STIM1 gene. So these patients have both muscle weakness, they have contractures, and they have tubular aggregates in the muscles. But what they do have in addition is they often have a more muscle pain phenotype, so they're often mistaken as muscle pain syndromes or even clinically suspected of having myositis or something else. But they also have calcium disturbances in blood. They have often a small or even absent spleen, and they have platelet abnormalities. And the reason for that is that this particular gene plays a role with the calcium channels in muscle. So coming to the more complex scenario, the digenic, polygenic, and the modifiers. And again, I come to a clinical example. So this is a family that Rita Horvath and colleagues examined more than 10 years ago in Munich. A family whereby two of the boys did in fact have a very severe childhood disease. They were on the intensive care unit, and what their muscle biopsy showed was near complete absence of cytochrome oxidase, of COX. However, these boys survived this very severe episode of floppiness, being respirated, etc., and without any specific treatment recovered. And what also recovered is the COX in their muscle. So that's from the same patients at age of 9 years. And this is a very rare disease that has been described previously by Billy DiMauro and others as reversible infantile COX deficiency. So while the majority of infantile COX deficiencies are of course not reversible and are lethal, in fact, these children do actually grow up and have minimal disabilities later in life if they survive this very severe period. But what was also interesting to see is that their mom, who is clinically unaffected, she is mosaic for COX negative fibers in her muscle. So if you look at their pedigree, so these are the two boys, then it was obvious that two relatives, an aunt and an uncle, did have the same condition, and there was a maternal inheritance suspected. And to make a long story short, Rita then discovered a particular tRNA mutation in the mitochondrial DNA that segregated, and all patients that were found across the world with this particular disease have this particular mutation from whatever ethnic background. So that mutation was clearly linked to disease. However, this wasn't the full explanation because in fact this particular mutation in the mitochondrial DNA encoded tRNA is present in the general population in about 1 in 1,000. So we should have far more of these patients if that would be the only cause. So it's really not fully penetrant or not sufficient to cause the disease. In addition, many other members in the family do actually have exactly the same mitochondrial DNA because mitochondrial DNA is maternally inherited. So, and this is shown on this slide. So this is the family a few years later when Rita visited them again and brought them together for further studies. So these are the three people with that had the condition initially, now a bit older than in the first picture. But all the other people on this slide, they also have the same tRNA mutation. So how is that possible? So we then did additional genetic studies, and in this case, exome sequencing. So, and in those patients who developed the disease, in the majority of them, she found additional strong pathogenic mutations in the nuclear genome. And in fact, in mostly tRNA synthetase gene, like this ERS2 gene. And while these genes were already linked to disease, they were only linked to recessive disease. So usually if you had an ERS2 disease, you need 2 mutations, B allelic mutations. So these patients here in these pedigrees only have 1 mutation, which by itself, again, would not be sufficient to cause disease. But in combination with the mitochondrial tRNA mutation, that is most likely the explanation for this condition. And that then makes also sense with the population frequencies. To make the story even a little bit more complicated, even those patients that have the 2 mutations, not all patients do develop the same severity of the disease, and it's still not fully penetrant. And there's clear environmental and epigenetic factors that Rita has looked in that play a role here. For instance, during muscle development, there is a strong need for cysteine, and nutrition plays a role here. And maybe this is one of the potential avenues into therapy. However, what's clinically very important is that once kids with this severe condition and COX deficiency are identified in the clinic, well, if they carry this particular mtDNA mutation, then in fact the prognosis is very good in contrast to the prognosis for the patients who do not have this mutation. Therefore, it has a high predictive value, and these patients, any effort should be taken, of course, to keep them alive, to get through that period of crisis. I switch gears now a little bit, and I said I would take out the scare of genomics and genetics for clinicians. So there's tools now out there and infrastructures that may help you to make sense of genetics for your muscle patients. And one of those is called RD Connect, which is a project that is currently funded by the European Commission, but will be taken forward as one of the central IT and bioinformatic infrastructures for rare diseases generally, but it's particularly useful also for rare muscle disease. So in short, what is this doing in terms of your exomes? So once you have sequenced the exome of a patient in whatever sequencing lab, that data gets archived and deposited and then run through a standard bioinformatics pipeline, and then becomes available at the RD Connect genome-phenome analysis platform in Barcelona. At the same time, a clinical phenotype is being provided to the platform, so that at the platform level, you do have, in fact, access to both the exome information as well as a clinical phenotype in HPO terms. And that allows you as clinician or a researcher with very little bioinformatics training online to analyze your patient's genetic and genomic data with analysis tools that are being provided for free. But what this also does, if more and more people do that, and the people who work on muscle disease are particularly good in this, more and more data on rare muscle diseases becomes available through the RD Connect platform. So this is a form of data sharing that is particularly important for rare disease, because each individual clinician or each individual center may just have one patient with a particular genetic defect. So you need to reach out to your colleagues, and a modern way to do this is through RD Connect. So in short, you can analyze your own undiagnosed patients, but you can also search for other patients with a related genotype or phenotype, for instance, for a specific muscle disease. This is how then the interface looks like. You basically can look through the exome of your patient, and you can use a predefined gene list, so basically a virtual panel, like the muscle gene table from neuromuscular disorders, or you can create your own gene table through the HPO terms that are associated with the phenotype of your patient. You can look across all samples for variants in specific genes or for variants in that particular gene that you came across in your patient. And then again, if you have a long list of variants in different genes for your patient and you don't really know which gene is the most likely one that causes the disease in your patient, then in fact you can use another tool, it's called Exomizer, that creates an algorithm and computes the likelihood of a particular gene or variant to be associated with a phenotype of your patient. You can also look at runs of homozygosity. That's particularly useful for patients from consanguineous families, and that helps you to limit down the number of homozygous variants that are not isolated but are situated in longer homozygous blocks and more likely to be associated with the disease in your consanguineous families. So what I want to stress with this slide here is that while you do your sequencing, this sequence is being deposited and analyzed. This goes along with a phenotypic record. This looks all pretty straightforward, and in fact it is, as long as you keep to certain standards. So standards are critically important in this business. So first of all, the consents need to be standardized. Your patients need to be informed and agree to having their exome or their genome sequenced, but also having their data shared with other centers and with other interested researchers. Then phenotypic standards are critically important, and this is being done through the human phenotype ontology and through the orphaned rare disease ontology. And I just briefly say, why is that important? Well, we can all describe our patients very well if we explain this face-to-face or in a letter, and that's probably even a better phenotype than whatever the computers could come up with. However, if you want to exchange data on a large scale, and we now sequence hundreds of patients every day worldwide, then it doesn't work anymore to send patient letters around or pick up the phone and just talk to your colleague. You need to get computers involved to make the matchmaking and find your second family. And this is where it's critically important to use ontologies and for the gene identification, the human phenotype ontology has become the, let's say, the industry standard. And why is that the case? Well, this is not just putting a standardized term to a certain feature that you see in your patient, to a certain symptom, but it also puts it in a logical hierarchy. So if you go from something that's quite general, the abnormality of muscle, to muscle weakness, to proximal muscle weakness in the lower limbs, so that's the most specific symptom here, then in fact there is a certain relation between proximal muscle weakness in the lower limbs and muscle weakness generally. So they are not that far apart. So a patient with a gene in a defect that shows maybe distal muscle weakness, if you come across that same gene in a patient who has ophthalmoplegia, well, as a clinician, you think, well, maybe there's a correlation. There's also a form of muscle weakness, right? But the computers wouldn't know that as long as you haven't put this into a standardized hierarchical ontology. And for this, we use the human phenotype ontology. And this is something I think we as clinicians need to get a little bit used to, but there's very easy to use tools to actually make that work. So there's two things that I want to convey to getting the sting out of the genetics and the genomics and the scare. So we shouldn't leave it to the geneticists or to the bioinformaticians. We should get involved and to be involved through what I told you about RD Connect. There's two ways. Scientists are, of course, invited to actually request access to the database. So everyone who has a research interest can do that, whether they contribute data themselves or whether they just want to mine the data because they came across an interesting gene in their frog or their mouse model. So that's an invitation, and you can sign up for this. It's a controlled access database, so it's not openly on the internet, and this is purely for the reason because this is private genetic and genomic data of patients, so it's privacy protected. The clinicians are, of course, invited to analyze their own patients on the platform and, of course, involve their patients through appropriate consent for next-generation sequencing and data sharing, but also to feedback results to their patients and include patients in other research because, of course, finding a gene or finding the variants that cause the disease in your patient is just the start of the journey. As I've shown you before, there needs to be validation in new genes, or there might be even opening up of new therapeutic avenues for some of these patients. So we think that this is now ready, in fact, to be used by the neuromuscular community. The RD-Connect database is, in fact, enriched in neuromuscular exomes because we have been the first to share our data through this. Other rare diseases are invited too. But it will be sustained and has already secured funding from another large European project, SolveRD, is becoming part of the European Joint Co-Fund with more than 20,000 data sets already lined up and partners with the European reference networks, particularly EuroNMD, the Neuromuscular European Reference Network. And this is my final slide to thank all the people and groups that have been involved in the research, and also particularly my new homes in Freiburg and in Barcelona. Thank you very much.
Thank you very much. You know, as members of the Scientific and Program Committee, we try and choose speakers who are engaging, knowledgeable, and accessible. And Dr. Lockmuller and the others have exemplified that, I think, to a T. So we do have some time for just a few questions. If you have any questions, please come to the microphone. Is it still there? What happened to the microphone? Ah, there it is. Okay. It looks like everybody's ready for a break, and he explained things so well to everybody that everything's crystal clear. So thank all of you very much for coming to this plenary session, making it a great success.